So thank you for bearing with me a little late. Not keeping a very good health for the last week, but all feeling fine now. And I would be presenting on something which would be very interesting to you guys. So I'm sharing my screen. So is my screen visible? Hello?
Yes.
Yeah, okay. So what I'm talking about now is a very interesting feature that most of us, when they get a rent in a situation where a lot of nuclear material and epinuclear material is still there, and there's a risk that all this material may fall into the vitreous cavity, and then the case will get handed over to a retina specialist. But there have been ways devised to prevent such a situation, and there have been two ways. One of the ways which I'm going to present to you is a contact lens scaffold. So the other way was an IOL scaffold, which has been very popular for so many years. So these are the two options. I have done both these techniques, and I realized that in an IOL scaffold, the thickness of the lens in the center is quite a bit. Therefore, the residual nuclear pieces which it is supporting are very close to the endothelium. And if they are hard, they would need more phacoenergy with resultant injury to the endothelium. However, if we are using a contact lens as a scaffold, it is much thinner, 100 microns in the center. So these nuclear pieces would be a little further away from the endothelium, and therefore probably less damage to the endothelium. So let us show you the two situations. The first situation is we had a PC rent, a large nuclear material. We wanted to prevent it from falling into the vitreous cavity once we break it up into small pieces and try to emulsify it. So we have put in place a 3-piece IOL over the iris, and this acts as a scaffold over which we are dissolving the nuclear material. The nuclear material, once dissolved, you can move this lens into the sulcus. A great technique, but at times you could see conditions like this because of the proximity of the nuclear material to the endothelium. You could also have situations where there is still a lot of epinuclear material under the lens, which one may find it difficult to take out, and a lot of cortical material under the lens, which may be difficult to take out. So can we have an alternative system which can serve all our purposes? So here is one. It is with a voiceover, and enjoy the show for the next 5 minutes till I come back with my comments.
Immediately fill up chamber with viscoelastic before withdrawing the irrigation. Put in an NTL chamber maintainer attached to a bottle height of 30 centimeters and do orbit check. Once a basic cleanup is done, one can evaluate what should be the next step. Because we have quite a few nuclear pieces here, we decide to use bandaged contact lens as a scaffold. The bandaged contact lens is injected into the eye. We open it up over the iris. In the process, hide the nuclear pieces in the cavity of the iris. Now the bandage contact lens is fully open and is working as a scaffold. So with faithful low power settings, we emulsify the nuclear pieces and take them out without fear of these pieces falling into the trace. We can see large chunks of epinucleus lying there. So the flexibility of the bandage contact lens allows us to bring these pieces out of the capsular bag through the pupil under the contact lens and then guided over the contact lens. Not there in the concavity of the PCR and without risk of the debris falling into the nucleus. We no need to PCR, so we can just simply hold it with any forceps and bring it out. And that exposes the underlying cortex. We use a 23 gauge retractor as a degating aspirating device, and at the same time, it also functions as a retractor. So, in foot pedal position 2, is working as an irrigation aspiration system, and we can hold these out the cortex from the capsular bag, and in foot pedal position 3, the cutter is activated and we cut and remove the cortex along with any attached vitreous. In this way, we can go to all the nooks and crevices and ensure a proper clean out of the cortex on the capsular bag. We inject a 3-piece IOL under cover of irrigation by the ACM. The lens opens up over the iris, can be dialed into the surface. So this is surface fixated, and an optic capture stabilizes the lens in the center. This is how the eye looks. Next to spot. Here, the vision is 2020. The endothelial cell count shows the 15% drop compared to the other eye at 3 months. A formula refined of 9 millimeters used to make the BCL current. BCL is placed on the corneal block and with the defined ordinal speed. And this is how to function this, which is good as a scaffold.
So, what you noticed in this presentation was one, the ease of injecting a contact lens which is acting as a scaffold within the eye over the iris. At this juncture, when I made this video, the size of the lens we used was 9 mm. Now we use a size of 9.5. We experimented with the size of 10 also, but we found 9.5 size dia to be the most suitable. Some people had apprehensions that a thin contact lens can fold and kind of drop into the vitreous. We have not had a single such case, probably because the thickness of the lens is more than an ordinary contact lens. The lens is 100 microns thick in the center. So it has enough structural integrity not to collapse and fall. Once all the nuclear materials are removed and the contact lens is removed, the area is so clear to you that slowly and meticulously you can clean up the whole area with the techniques shown. In fact, the most important part of this surgical technique is the anterior chamber maintenance. Once the ACM is in place with a bottle height of 45, which gives you an IOP of 30, and your phaco system is also working on a low IOP of 30, so that at all times an IOP of 30 is maintained. At this IOP, the chamber is very stable.
Are you moving your slides, Sanjay, or are you talking extempore?
No, I'm doing, sorry. Okay.
Because your slides are not moving.
Yeah. So just
okay, so
thank you. No,
Thank you, Sanjay. I think that was a very innovative technique, but I think there are a lot of apprehensions already on the panelist dais. So I think each one of them will, ask a question.
First, I want to ask you whether you autoclave this contact lens before inserting inside the eye, or use it straight away from the bottle, and then next comment will come from Dr. Kamal Kapoor.
Okay, so the first question, whether this lens is to be sterilized or straight into the eye. So what we do now is, we have these lenses made by a local company and they are steam autoclaved. We keep that stock with us, and the validity of that sterilization is 6 months. In fact, all hydrophilic lenses, even ICLs, are steam sterilized.
Yes.
And ICLs have a sterility of 2 years.
You can't autoclave them,
So you can't autoclave them.
Yeah.
But steam sterilization at a certain level is an acceptable technique. And then we chip it to the size we require and put it in the eye. And since it is only there for a moment, we have not had any infection issues so far. In about 7 or 8 cases we have done so far in the last 5 years.
Okay.
Thank you.
Kamal, you have a question?
Dr. Sanjay, it's a very, very innovative thought indeed. My only question is that in case you have a large rent sitting there, and with the fluid flow coming, even if it is a 40 millimeter or 45 centimeter of bottle height, and there is some fluctuation because you are still trying to suck out the nuclear pieces, these fluctuations itself would probably want, promote the lens to bend backwards, and it can, once it starts rolling out, because a lot of times, especially when you're using this in post PRK and C3R, sometimes even when you pick it out of the little box, it just rolls on itself because of the surface tension. So these fluctuations may induce a fold and it can probably slip in. Just a curious thought.
I think
so that is what I was talking about.
Sanjay, adding to that, adding to what Kamal Kapoor is saying, we really don't know what is the interactions or the dynamics between the contact lens and the nuclear material, contact lens and the cortex, contact lens and the vitreous behind, and when it is all admixed, that is, nuclear material and cortex and vitreous and the contact lens. And of course, that fear is always there that if your rent is too large, then it might just drop down and then you may have a problem in picking it up.
Okay, so let me answer that.
And the third concern, so you can answer
Sanjay,
all the concerns.
Just one more thing. Since this BCL is actually a hydrophilic material, and there is always chance that hydrophilic IOLs also, there is greater propensity of slipping through the rent compared to the hydrophobic material, because they just slip through the rent. So if the rent is moderate or large, then I think there are genuine apprehension that it might slip, although it is 9.5 millimeter. but because of the fluctuation in the interior chamber, there are chances. So, although it's a very, I think, innovative technique.
Okay, great. So let me answer those concerns. Number one, the rule is the IOP should be low. I'm working at an IOP of 30, both from the phaco machine and the ACM. The higher the IOP, the more the push on the lens, and the lens can kind of move backwards. Two, the thickness of the lens. The thicker the lens, the stronger its structure, less chances for it to fold. Right? And the size of the lens. If the lens is 9.5 or 10, it's kind of going up to the edge. And then, since the iris is there, which is working as a scaffold to the contact lens, so the chances of the contact lens going through that comparatively smaller pupil aperture, because with all these manipulations, many a times the pupil does come down. But even if it doesn't come down, you have a fair amount of support by the iris for the contact lens. And the contact lens is there only for a moment. It's just there for probably less than half a minute. So all these structures, the nucleus, the cortex, they would have very limited time of exposure with this contact lens.
Okay. Thank you, Sanjay. Thank you.